Hello class, welcome to Chapter 15, Respiratory Emergencies. After students complete this chapter and the related coursework, they will understand the significance and characteristics of respiratory emergencies in infant, child, and adult populations. Students should be able to demonstrate a fundamental comprehension on the following topics: respiratory anatomy and physiology, pathophysiology, signs and symptoms of various respiratory etiologies, asthma, COPD, and pneumonia, and the assessment and management necessary to provide basic care in the pre-hospital setting. Introduction. EMTs often encounter patients complaining of dyspnea. Dyspnea is feeling short of breath or having difficulty breathing. Dyspnea can be caused by many different conditions: common cold, asthma, heart failure, pulmonary embolism. Dyspnea cause can be difficult to determine. Several different problems may contribute to a patient's dyspnea at the same time. Even without a definitive diagnosis, you may still be able to save a patient's life. Anatomy of the respiratory system. The respiratory system consists of all structures that contribute to breathing, including the diaphragm, chest wall muscles, accessory muscles for breathing, nerves from the brain and spinal cord to those muscles. The upper airway consists of all the autonomic structures above the vocal cords: nose and mouth, jaw, oral cavity, pharynx, and larynx, the end of the upper airway. This figure shows the components of the upper and lower airways. The principal function of the lungs is respiration. Respiration is the exchange of oxygen and carbon dioxide. Air travels through the trachea into the lungs, then onto the bronchi, the larger airways, bronchioles, smaller airways, and alveoli. The alveoli are where the actual exchange of oxygen and carbon dioxide takes place. Physiology of respiration. There are two processes that occur during respiration: inhalation, the act of breathing in or inhaling; expiration, the act of breathing out or exhaling. Oxygen is provided to the blood and carbon dioxide is removed from it. In healthy lungs, this exchange of gases takes place rapidly at the level of the alveoli. This figure shows a close-up of the exchange of oxygen and carbon dioxide within the alveoli. The alveoli lie against the pulmonary capillary vessels. Oxygen passes freely through tiny passages in the alveolar wall into these capillaries through the process of diffusion. It is then carried to the heart, which pumps the oxygen throughout the body. Carbon dioxide returns to the lungs. It diffuses back into the alveoli. It travels back up the bronchial tree and exits through the upper airways during exhalation. The brain stem senses the level of carbon dioxide in the arterial blood. If the level of carbon dioxide drops too low, the person automatically breathes at a slower rate and less deeply. As a result, the less carbon dioxide is expired and the levels of blood return to normal. If the level of carbon dioxide rises above normal, the person breathes more rapidly and more deeply. More carbon dioxide diffuses out of the blood system and the levels in the blood are thus lowered. Pathophysiology. The proper exchange of oxygen and carbon dioxide can be hindered by abnormal or pathologic conditions in the anatomy of the airway, disease processes, traumatic conditions, pulmonary vessels which may have abnormalities that interfere with blood flow. The EMT must be able to recognize the signs and symptoms of inadequate breathing, know what to do about it, carbon dioxide retention, and hypoxic drive. Patients will sometimes have an elevated level of carbon dioxide in the arterial blood. Potential causes: exhalation process may be impaired by lung disease. The body may naturally produce too much carbon dioxide. If levels stay high for a period of years, the respiratory center in the brain may not function properly. It could signify chronic carbon dioxide retention. The brain gradually accommodates high levels of carbon dioxide, then uses a backup system to control breathing based on low levels of oxygen known as hypoxic drive. Use caution when administering oxygen to these patients. Causes of dyspnea. Dyspnea can be caused by many medical problems. If the brain is deprived of oxygen, a patient may not be alert enough to complain. Altered mental status may be a sign that the brain is dysfunctional because of severe hypoxia. Patients often have difficulty breathing or hypoxia with the following medical conditions: pulmonary edema, hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental or industrial exposure, carbon monoxide poisoning, or drug overdose. Be aware that one or more of the following situations may exist in the dyspneic patient. Gas exchange between the alveoli and pulmonary circulation is obstructed by fluid in the lung, infection, or collapsed alveoli. The alveoli are damaged and cannot transport gases properly across their own walls. The air passages are obstructed by muscle spasm, mucus, or weakened floppy airway walls. Blood flow to the lungs is obstructed by blood clots. The pleural space is filled with air or excess fluid, so the lungs cannot properly expand. This table shows signs and symptoms of inadequate breathing. Besides shortness of breath, a patient with dyspnea may also report chest tightness or air hunger. Dyspnea is a common complaint in patients with cardiopulmonary diseases. Congestive heart failure causes the heart to pump inefficiently and deprives the body of oxygen. Pulmonary edema is a condition associated with congestive heart failure. Severe pain can cause a patient to experience rapid, shallow breathing without the presence of a primary pulmonary dysfunction. In some patients, breathing deeply causes pain because it causes expansion of the chest wall. Upper or lower airway infection. Infectious diseases can cause dyspnea, may affect all parts of the airway. Some cause mild discomfort, some require aggressive respiratory support. Oxygenation is a problem of inadequate oxygen delivery to the tissues. The problem causing dyspnea is always some form of obstruction. Mucus and secretions obstructing airflow in major passages, cold or diphtheria. Swelling and soft tissues in upper airways is epiglottis or coop. Impaired exchange of gases in the alveoli is pneumonia. Be diligent about the use of appropriate PPE when in contact with patients who have infectious diseases. Coop. The inflammation and swelling of the pharynx, larynx, and trachea, especially seen in children between 6 months and 3 years of age. Easily passed between children. Hallmark signs of Coop are stridor and a seal bark cough. Coop often responds well to the administration of humidified oxygen. Epiglottitis, or the inflammation of the epiglottis, usually as a result of a bacterial infection. More prominent in children, but can occur in adults. Usually develops suddenly. Children look ill, report a very sore throat, and have a high fever, often found in the tripod position and drooling. Treat children gently and try not to make them cry. Position comfortably, provide high flow oxygen, and do not put anything in their mouths. Respiratory syncytial virus. Respiratory syncytial virus, or RSV, is a common cause of illness in young children. Causes an infection in the lungs and breathing passages. It's highly contagious. Look for signs of dehydration. Treat airway and breathing problems as appropriate. Humidify oxygen is helpful if available. Bronchiolitis. Viral illness that occurs due to RSV usually affects newborns and toddlers. Bronchioles become inflamed, swell, and fill with mucus. Provide oxygen therapy and frequently reassess for signs of respiratory distress. Pneumonia, general term that refers to an infection of the lungs, often a secondary infection that begins after an upper respiratory tract infection, can be caused by a virus or bacterium, by chemical injury or direct lung injury. Bacterial pneumonia will come on quickly and result in high fevers. Viral pneumonia presents more gradually and is less severe. Pneumonia especially affects people who are chronically or terminally ill. Signs and symptoms of pneumonia include rapid or labored breathing in children, blue or gray lips or fingernails, fever, dry skin, decreased skin tremor, exertion, dyspnea, productive cough, chest discomfort and pain, headache, nausea and vomiting, musculoskeletal pain, weight loss, confusion, diminished breath sounds. If possible, assess temperature to determine presence of fever. Provide airway support and supplemental oxygen. Pertussis, whooping cough, an airborne bacterial infection that mostly affects children younger than 6 years, highly contagious and is passed through droplet infection. Patients will be feverish and exhibit a whoop sound after a coughing attack. Coughing spells can last for more than a minute, during which the child may turn red or purple. Watch for signs of dehydration. Suction may be necessary. Pertussis in adults can cause a severe respiratory infection. Influenza Type A, an animal respiratory disease that has mutated to infect humans. In 2009, the H1N1 strain of influenza type became pandemic, an outbreak that occurs on a global scale. Symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. May lead to pneumonia or dehydration. Tuberculosis or TB. TB is a bacterial infection that most commonly affects the lungs. It can also be found in almost any other organ, can remain inactive for years before producing any symptoms. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. With severe infection, patients will experience shortness of breath, coughing, productive sputum, bloody sputum, and chest pain. Prevalence is higher in the homeless people, prison inmates, and nursing home residents. TB is also found in persons who abuse intravenous drugs or alcohol, or those with HIV. If you suspect a patient may have active TB, you need to wear at minimum, gloves, eye protection, and an N95 respirator. Acute pulmonary edema. Sometimes the heart muscle cannot circulate blood properly. The left side of the heart cannot remove blood from the lungs as fast as the right side delivers it. Fluid builds up within the alveoli and in the lung tissue. This accumulation of fluid is referred to as pulmonary edema, usually results from congestive heart failure. Patients usually experience dyspnea with rapid shallow respirations. In severe cases, a frothy pink sputum forms at the nose and mouth. Most patients have long-standing history of chronic congestive heart failure that can be kept under control with medication. Not all patients with pulmonary edema have heart disease. Inhaling large amounts of smoke or toxic chemical fumes, traumatic injuries to the chest, and exposure to high altitudes can produce pulmonary edema. This figure shows fluid filling the alveoli in pulmonary edema. Chronic obstructive pulmonary disease, COPD. Slow process of dilation and disruption of airways and alveoli caused by chronic bronchial obstruction. COPD is an umbrella term used to describe a few lung diseases, including emphysema and chronic bronchitis. Ongoing irritation of the trachea and bronchial may be a result of direct lung and airway damage from repeated infections or inhalation of toxic gases or particles. Most often results from cigarette smoking. Tobacco smoke is a bronchial irritant and can create chronic bronchitis and ongoing irritation of the trachea and bronchiole. With bronchitis, excessive mucus is constantly produced, obstructing small airways and alveoli. Airways are weakened as the lungs' protective devices are destroyed. Chronic oxygenation problems can also lead to right heart failure and fluid retention. Pneumonia develops easily. Repeated episodes of irritation and pneumonia cause scarring in the lung and some dilation of the obstructed alveoli, leading to COPD. Emphysema is the most common type of COPD. Emphysema is the loss of elastic material in the lungs as a result of chronic stretching of the alveoli. Smoking can directly destroy the elasticity of the lung tissue. Most patients with COPD have elements of both chronic bronchitis and emphysema. Most patients will chronically produce sputum, have a chronic cough, and have difficulty expelling air from their lungs, with long expiration phases and wheezing. This figure shows damage to the alveoli, characteristic of COPD. Wet lungs versus dry lungs. Patients with pulmonary edema caused most often by congestive heart failure will often have wet lung sounds. Bronchi and crackles. A patient with COPD will often have dry lung sounds, wheezes. The wet lung sounds of pulmonary edema and the dry lung sounds of COPD can sometimes be confused. Do not assume that all COPD patients have wheezing and all congestive heart failure patients have rales. Patients with COPD wheeze because of bronchial constriction. Present with shortness of breath, breathing gets progressively worse. Have trouble breathing with exertion, have chronic coughing and thick sputum, are usually long-term smokers with a thin barrel chest appearance, often have slower onset symptoms. Patients with congestive heart failure experience a fluid overload in the lung, which may develop quickly from a failing pump. Asthma, hay fever, and anaphylaxis. Asthma, hay fever, and anaphylaxis result from an allergic reaction to an inhaled, ingested, or injected substance. In some cases, there is no identifiable allergen that triggers the immune system. Asthma, an acute spasm of the bronchioles associated with excess mucus production and swelling of the mucosal linings of the respiratory passages. Approximately 25 million Americans have asthma. Affects all ages but is most prevalent in children 5 to 7 years of age. Produces a characteristic wheezing caused by partially obstructed airways. Wheezing is indicative of a partial lower airway obstruction. Wheezing may be so loud that you can hear it without a stethoscope. In other cases, the airways are so blocked that no air movement is heard. An acute asthma attack may be caused by allergic reaction to specific foods or some other allergen. Attacks may also be caused by severe emotional distress, exercise, and respiratory infections. In its most severe form, an allergic reaction can produce anaphylaxis, may result in respiratory distress severe enough to lead to coma or death. Most patients with asthma are familiar with the symptoms and know when an attack is imminent. Listen to the needs of the patient. They often know exactly what they need. Hay fever, allergic rhinitis, causes cold-like symptoms including a running nose, sneezing, congestion, and sinus pressure. Symptoms are caused by an allergic reaction, usually to outdoor airborne allergens. Allergens include pollen, dust mites, and pet dander. Patients with hay fever tend to be atopic, meaning they are more likely to have other allergies. Anaphylactic reactions. Severe allergic reactions characterized by severe airway swelling and dilation of blood vessels. Signs and symptoms may be similar to asthma. The airway can swell so much that total obstruction is possible. Patients may or may not be aware of their sensitivity to certain substances. In most cases, epinephrine is the treatment of choice. Oxygen and Antihistamines are also helpful. Spontaneous pneumothorax. Pneumothorax is the partial or total accumulation of air in the pleural space. It is most often caused by trauma. May also be caused by medical conditions. A vacuum-like pressure in the pleural space keeps the lungs inflated. When the surface of the lung is disrupted, air escapes into the pleural cavity, and the negative vacuum pressure is lost. The accumulation of air in the pleural space may be mild or severe. Spontaneous pneumothorax occurs in patients with certain lung infections or in young people born with weak areas of the lung. People with emphysema or asthma are at higher risks. Tall, thin males are also at a higher risk. A patient with spontaneous pneumothorax becomes dyspneic and might complain of pleuric chest pain, a sharp, stabbing pain on one side that is worse during breathing or with certain movements of the chest wall. You can sometimes tell that breath sounds are absent or decreased on the affected side. Pleural effusion. A pleural effusion is a collection of fluid outside the lung. It compresses the lung and causes dyspnea. It can be caused by an irritation, infection, congestive heart failure, or cancer. Patients feel better if they are sitting upright. Obstruction of the airway. A patient with dyspnea may have a mechanical obstruction. Treat quickly. In semi-conscious and unconscious patients, the obstruction may be the result of aspiration or vomitus or a foreign object, or improper positioning of the head causing the tongue to block the airway. If the patient was eating just before the onset of dyspnea, always consider the possibility of foreign body obstruction. This figure shows obstruction of the airway by a foreign body and the tongue. Pulmonary embolism. An embolus is anything in the circulatory system that moves from its point of origin to a distant site and lodges there, obstructing subsequent blood flow in the area. Circulation can be cut off completely or partially. Emboli can result in serious life-threatening conditions. Emboli can be fragments of blood clots in an artery or vein that break off and travel through the blood system. They can also be foreign bodies that enter the circulation, such as an air bubble. Pulmonary embolism is a blood clot that circulates through the venous system. May be a result of damage to the lining of the vestibules, a tendency for blood to clot unusually fast, slow blood flow in lower extremities, often the result of long-term bed rest. Signs and symptoms of pulmonary emboli include the following: dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, hematosis, with a large enough embolism, complete obstruction and of the output of blood from the right side of the heart can result in sudden death. Hyperventilation. Hyperventilation is defined as overbreathing to the point that the level of arterial carbon dioxide falls below normal. This may be an indicator of life-threatening illness. The body may be trying to compensate for acidosis, the buildup of excess acid in blood or body tissues. Can result in alkalosis, the buildup of excess base or lack of acids in the body fluids. This can cause symptoms of hyperventilation syndrome, panic attack, including anxiety, dizziness, numbness, tingling of hands and feet, painful spasms of hand and or feet. The decision whether hyperventilation is being caused by a life-threatening illness or a panic attack should not be made outside the hospital. Verbally instruct the patient to slow his or her breathing. If that does not work, give supplemental oxygen and transport to the hospital. Environmental or industrial exposure. Pesticides, cleaning solutions, chemicals, chlorine, and other gases can be accidentally released at an industrial site and inhaled by employees. Many industrial sites have their own medical fire or hazmat teams. Carbon monoxide poisoning. Carbon monoxide is an odorless and highly poisonous, leading cause of accidental poisoning deaths in the United States. Carbon monoxide is produced by fuel-burning household appliances and is present in smoke. People who have carbon monoxide poisoning complain of flu-like symptoms and even dyspnea. Do not put yourself at risk. High-flow oxygen by non-rebreather mask is the best treatment for conscious patients. Patients who are unconscious or have an altered level of consciousness may need full airway control. Patient assessment. Scene size up. Scene safety. Use standard precautions and use PPE. Consider the possibility of an infectious disease or toxic substance. If there are multiple people with dyspnea, consider the possibility of an airborne hazardous material release. Mechanism of injury, nature of illness. If in question, ask why 911 was activated. By questioning the patient, family, and/or bystanders, you should be able to determine the NOI. Identify immediate life threats. Problems with the ABCs. If any major problem is identified, treat it immediately. Form a general impression. Form an overall general impression of the patient's level of distress. Note the age and position of the patient. Is the patient calm or anxious? Use the AVPU scale to check for responsiveness. Ask the patient about his or her chief complaint. Assessing the ABCs. Make sure airway is patent and adequate. If there is any question about airway patency, it must be opened immediately using the head tilt, chin lift, or jaw thrust maneuver. Evaluate whether the patient's breathing is adequate. Assess the rate, rhythm, and quality of respirations. Ask yourself the following questions. Is the air going in? Does the chest rise and fall with each breath? Is the rate adequate with the victim's age? Assess breath sounds. Obtaining breath sounds is an important step. Listen over the bare chest. Determine whether breath sounds are normal, vesicular breath sounds, bronchial breath sounds, or decreased, absent, or abnormal. Check breath sounds on the right and left sides of the chest and compare. Listen to breath sounds for a full respiratory cycle. Abnormal sounds include snoring, wheezing, crackles, rhonchi, and stridor. Assess circulation. Evaluate for shock and bleeding. Assess capillary refill in infants and children. Assess perfusion by evaluating skin color, temperature, and condition. Reassess and identify any life threats to your patient. They would include any of the following signs and symptoms. Problems with the ABCs. Poor initial general impression. Unresponsiveness. Potential hypoperfusion or shock. Chest pain associated with low blood pressure. Severe pain anywhere. Excessive bleeding. Make transport decision. If the patient's condition is unstable and there is a possible life threat, address the life threat. Proceed with rapid transport. History taking. Investigate the patient's chief complaint. Objective and subjective observations are important in building a general assessment. Report pertinent negatives. Find out what the patient has done for the breathing problem. Different respiratory complaints offer different clues and different challenges. Try to determine the patient's baseline status. With patients in respiratory distress, a sample history can be collected from bystanders or family if they are present. Be sure to ask the following about the patient in respiratory distress. What is the patient's general state of health? Has the patient had any childhood or adult diseases? Have there been any recent surgical procedures or hospitalizations? Have there been any traumatic injuries? The OPQRST assessment can be modified to gather information about the breathing problem. When did the breathing problem begin? Onset. What makes the breathing difficulty worse or better? How does the breathing feel? Is the discomfort located or does it move? How much of a problem is the patient having? Is the problem continuous or intermittent? If it is intermittent, how frequently does it occur and how long does it last? The paced assessment is an alternative assessment for a complaint of shortness of breath or difficulty breathing. Progression, associated chest pain, sputum, talking tiredness, exercise tolerance. Secondary assessment. The secondary assessment is a more in-depth assessment of body systems. Only proceed with secondary assessment if life threats have been addressed and treated. Keep an open mind, gather as complete a history as possible and perform a secondary assessment of the respiratory system, the cardiovascular system, the skin, blood pressure, the neurologic system. Use monitoring devices if you have them. Secondary assessment of COPD versus congestive heart failure. Look for signs of COPD. Patients with COPD are usually older than 50 years of age, often have a history of lung problems, are almost always long-term active or former cigarette smokers, complain of tightness in the chest and constant fatigue. Chest may have a barrel-like appearance, often use accessory muscles to breathe, exhibit abnormal breath sounds. Reassessment. Repeat the primary assessment. Determine if there have been changes in the patient's condition. Confirm the adequacy of interventions and patient status. If the patient's condition is stable and no life threats exist, vital signs should be obtained at least every 15 minutes. Interventions for respiratory problems may include providing oxygen via a non-rebreathing mask at 15 liters per minute, providing positive pressure ventilations using a BVM pocket mask or flow-restricted oxygen-powered device, using airway management techniques such as an oropharyngeal airway, nasopharyngeal airway, suctioning, and airway positioning, providing non-invasive ventilated support with continuous positive airway pressure, positioning the patient in a high Fowler's position or position of choice, assisting the patient with respiratory medications, communicate all relevant information to the staff at the receiving hospital. Emergency medical care. Management of respiratory distress. If a patient complains of difficulty breathing, you should administer supplemental oxygen immediately. Some patients may need CPAP or ventilator support with a BBVM. Take great care in monitoring respirations. Reevaluate respirations and the patient's response to oxygen at least every 5 minutes. Do not withhold oxygen in patients with COPD. The patient may have a meter-dose inhaler or small volume nebulizer. Consult medical control and make sure the medication is indicated. Ensure that there are no counterindications to a patient's condition. The patient is unable to help coordinate inhalation. The MDI or small volume nebulizer is not prescribed to this patient. You did not obtain permission from medical control. The medication is not permissible by local protocol. The patient has already met the maximum prescribed dose. The medication is expired. There are other counterindications specific to the medication. Most respiratory inhalation medications are used to relax the muscles that surround the air passages in the lungs, leading to dilation of the airways. Common side effects of inhalers: increased pulse rate, nervousness, muscle tremors. Medication from an inhaler is delivered through the respiratory tract to the lung. Treatment of specific conditions. Upper and lower airway infection. Administer humidified oxygen if available. Do not attempt to suction the airway or place an oropharyngeal airway in the patient with suspected epiglottitis. Position comfortably and transport promptly. Acute pulmonary edema. Provide 100% oxygen, suction if necessary, position comfortably. An unconscious patient may require full ventilatory support, including placement of an airway adjunct. Provide continuous positive airway pressure, CPAP, if indicated and allowed by protocol. Transport promptly. COPD. Assist with prescribed inhaler. Watch for side effects due to overuse. Position comfortably and transport promptly. Asthma, hay fever, and anaphylaxis. Asthma. Determine if asthma is really the problem. Be prepared to suction. Assist the asthma patient with prescribed inhaler. Provide aggressive airway management. Oxygen, prompt transport. A prolonged asthma attack that is unrelieved may progress into a condition known as status asthmatitis. This is a true emergency. Give oxygen and promptly transport. Hay fever. Hay fever is unlikely to need emergency treatment. Manage the airway and give oxygen according to the level of distress. Anaphylaxis. Remove the offending agent. Maintain the airway, transport rapidly. Administer epinephrine if allowed by local protocol. Spontaneous pneumothorax. Provide supplemental oxygen, transport promptly, and monitor carefully. Pleural effusion. Fluid removal must be done in the hospital. Provide oxygen and transport promptly. Obstruction of the airway. Partial obstruction. Provide supplemental oxygen and transport. Complete obstruction. Clear the obstruction and administer oxygen. Transport rapidly to the emergency department. Pulmonary embolism. Supplemental oxygen is mandatory. Position comfortably. If hemostasis is present, clear the airway immediately. Transport promptly. Hyperventilation. Complete airway primary assessment and gather history. Do not have the patient breathe in a paper bag. Reassure the patient and provide supplemental oxygen. Transport promptly. Environmental or industrial exposure. Ensure patients are decontaminated. Treat with oxygen, adjuncts, and suction based on presentation. Foreign body aspiration. Perform the appropriate airway cleaning technique specific to age. Provide oxygen and transport. Tracheostomy dysfunction. Your main goal is to establish a patent airway. Position comfortably. Provide suctioning to clear the obstruction. Once the obstruction is clear, oxygenate the patient. Asthma. For children, provide blow-by oxygen by holding the mask in front of the child's face. Use MDIs as you would with older patients. As with any chronic disease, asthma may be life-threatening in an older person. Cystic fibrosis. Genetic disorder that affects the lungs and digestive system. Predisposed children to repeated lung infections. Symptoms range from sinus congestion to wheezing and asthma-like complaints. Usually, parents or caregivers call EMS because the child has dyspnea. Suction and oxygenate as needed. Okay, class, let's go over some review questions. Review question 1. The process in which oxygen and carbon dioxide are exchanged in the lungs is called A. Respiration, B. Ventilation, C. Metabolism, or D. Inhalation. The correct answer is A. Respiration is defined as the exchange of gases between the body and its environment. The exchange of oxygen and carbon dioxide in the lungs is called pulmonary respiration. The exchange of oxygen and carbon dioxide at the cellular level is called cellular respiration. The correct answer is A. B. Ventilation. Ventilation is the exchange of air between the lungs and the environment. Metabolism is the series of processes by which food is converted into the energy and products needed to sustain life. Inhalation is the active muscular part of breathing. Review question 2. Which of the following respiratory diseases causes obstruction of the lower airway? Acute, asthma, epiglottitis, laryngitis. The correct answer is B. Asthma is a lower airway disease that causes the bronchioles in the lungs to constrict, resulting in various degrees of obstruction. Acute, epiglottitis, and laryngitis cause swelling, inflammation, and varying degrees of obstruction of the upper airway. Croup, this causes an upper airway obstruction. Asthma causes a lower airway obstruction by causing constriction of the bronchioles. Epiglottitis, this causes an upper airway obstruction. It's inflammation of the epiglottis. Laryngitis, this also causes upper airway obstruction. Review question 3. Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing? A. Tuberculosis, B. Croup, C. Diphtheria, D. Epiglottitis. The correct answer is A. Tuberculosis is a bacterial infection spread by cough. It is dangerous because many strains are resistant to antibiotics. Tuberculosis is the correct answer. Croup is an inflammatory condition of the larynx and trachea marked by a cough, hoarseness, and difficulty in breathing. Diphtheria is caused by a bacterium that attacks the membrane of the throat. Epiglottitis is an acute bacterial infection of the epiglottis. Review question 4. All of the following are causes of acute dyspnea except A. Asthma, B. Emphysema, C. Pneumothorax, or D. Pulmonary embolism. The correct answer is B. Emphysema, a form of COPD, is a chronic respiratory disease. Therefore, it presents with progressively worsening dyspnea. Asthma, pulmonary embolism, and pneumothorax are all acute conditions. Therefore, they typically present with an acute onset of dyspnea. Asthma is an acute condition with sudden onset of dyspnea. Emphysema is the correct answer. Pneumothorax and pulmonary embolism are both acute conditions that can cause a sudden onset of dyspnea. Review question 5. Bronchospasm is most often associated with answer A, asthma, answer B, bronchitis, answer C, pneumonia, answer D, pneumothorax. The correct answer is A. Asthma, a reactive airway disease, is caused by bronchial spasm, sustained constriction of the bronchioles. Common triggers to an acute asthma attack include environmental allergens, stress, and temperature changes. The correct answer is A. Asthma. Bronchitis is the inflammation of mucosal membranes in the bronchial tubes of the lungs. Pneumonia is an inflammation of one or both lungs. Pneumothorax is the presence of air or gas in the pleural cavity surrounding the lungs, causing pain and difficulty in breathing. Review question 6. A sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite supplemental oxygen is most consistent with A. Severe pneumonia, B. Myocardial infarction, C. A pulmonary embolism, D. A spontaneous pneumothorax. The correct answer is C. Signs of an acute pulmonary embolism include a sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite the administration of high-flow oxygen. Patients who are immobile for prolonged periods of time, confined to a hospital bed, are prone to pulmonary embolism. Severe pneumonia. This is an acute bacterial or viral infection associated with fever, cough, and productive sputum. Myocardial infarction. A heart attack is associated with chest pain, sudden onset of weakness, nausea, sweating, and discomfort. Pulmonary embolism is correct. A spontaneous pneumothorax. This is when air escapes into the pleural cavity. Albuterol, a beta-2 antagonist, is the generic name for A. alpint, B. metoprolol, C. brethine, D. Ventolin. The correct answer is D. Albuterol is the generic name for Ventolin. Albuterol is a beta antagonist which dilates the bronchioles and is commonly used to treat patients with asthma and other reactive airway diseases. A and B are both the trade name for metoprolol, also a beta-2 antagonist. Answer C is the trade name for terbutaline, also a beta-2 antagonist. D is the correct answer. Review question 8. An acute bacterial infection that results in swelling of the flap that covers the larynx during swallowing is called A. croup, B. laryngitis, C. epiglottitis, D. diphtheria. The correct answer is C. Epiglottitis. A potentially life-threatening illness is an acute bacterial infection that causes swelling of the epiglottis, the flap that covers the larynx, during swallowing. It is characterized by sudden onset of high fever, difficulty breathing, stridor, drooling, and varying degrees of hypoxemia. Croup. This is an inflammatory condition of the larynx and trachea marked by cough, hoarseness, and difficulty breathing. Laryngitis is an inflammation of the larynx, usually accompanied by hoarseness and coughing. The correct answer is C. Diphtheria is caused by a bacterium that attacks the membranes of the throat. Review question 9. A 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially when lying flat. He is coughing up pink, frothy secretions. The patient is most likely experiencing A. acute right heart failure, B. severe left heart failure, C. an acute onset of bronchitis, D. an acute pulmonary embolism. The correct answer is B. As a result of his recent heart attack, the left side of this patient's heart has been severely damaged. The left side of the heart is responsible for pumping oxygenated blood to the rest of the body. When it fails to do this, blood backs up in the lungs, resulting in pulmonary edema. Signs of pulmonary edema include dyspnea, especially when lying flat, rapid and shallow respirations, and in severe cases, coughing up pink, frothy sputum. Acute right heart failure causes a backup of blood in the systematic circulatory system and typically causes symptoms of peripheral edema in the hands and feet. B is the correct answer. Acute onset of bronchitis. This is an acute inflammation of the lungs associated with cough, increased sputum, fever, and tachypnea. An acute pulmonary embolism. This is a blood clot in the lungs and is seen with dyspnea, acute chest pain, cyanosis, tachypnea, and coughing up blood. Review question 10. Which of the following patients is breathing adequately? A 36-year-old man with cyanosis around the lips and irregular respirations. 29-year-old woman with respirations of 20 breaths per minute who is conscious and alert. C. A 22-year-old man with labored respirations at a rate of 28 breaths per minute and pale skin. D. A 59-year-old woman with difficulty breathing whose respirations are rapid and shallow. The correct answer is B. Adequate breathing in the adult is characterized by a respiratory rate between 12 and 20 breaths per minute. Good chest rise indicates adequate tidal volume, unlabeled breathing effort, non-altered mental status, and good perfusion to the skin, i.e. pink, warm, and dry. Answer A. A patient with irregular respirations is not breathing adequately. Cyanosis is a sign of hypoxia. B is the correct answer. Answer C. The normal adult rate of respirations is 12 to 20 breaths per minute. Answer D. A patient with adequate breathing has a normal rate and unlabored breathing effort. Okay, class. This concludes the lecture on Chapter 15, Respiratory Emergencies. Thank you for listening. If you have any questions or issues, please contact your instructor, and I'll see you in the next chapter.